The next panel that we're going to discuss is really a nice segue from the previous discussion that we just had, and this includes how and when to treat and the management of acute bleeding. And so we're going to have three different perspectives on this. We have Dr. Karen Strike, a physiotherapist with the Bleeding Disorders Program at the Hamilton Health Science Centre, Dr. Mark BELLETRUTTI, a pediatric hematologist at BC Children's and Women's Hospital, and Dr. Davide MATINO, an adult hematologist at McMaster. And so, as I mentioned, we'll do questions at the end of this session.
We weren't quite sure of the order. We were going to pull an audible and change our order of when we were presenting, but I thought I'd better check whose slides are first.
About to find out.
About to find out. Is it just the green button? No. Nothing's happening. Oh, it is. Yeah, so quick audible.
Our audible worked and what we wanted actually happened. Oh, there we go. Let's go back. Let's try and go back. You're getting a preview of Karen's slides. Keep going back. There we go. So I don't have a fancy Vancouver picture like Erica. What she also didn't mention is she took that picture in January because it's Vancouver. No, I'm just kidding. Although it did look like that in January, I think. We had a nice winter this year. So I'm going first as I guess the beginning of life stage as the pediatric treater, and I really wanted to focus my short time on three things. A lot of this stuff people already know, and actually have been mentioned in the previous session, and that, when we look at injuries, it's not always factor first anymore. It's as was so eloquently stated. Well, let's see where this goes, and when do I need to treat? And there's I think, especially in the beginning with a lot of our kids that we transitioned, it's a lot more calls to our team to discuss the injury or the situation that's coming. Maybe a few more visits that we wouldn't do in the past, where our patients just treated at home and called us if things weren't getting better. This is more, well, maybe, especially in the beginning of the transition, was, well, maybe you have to come and see us and we make a decision together and we see if there's anything different with the bleeds we're seeing. So yeah, it's a big change because, for ever, we were saying factor first, right? Give your factor, call us, and we'll decide on the next steps. And now that's completely changed, and we're having to, in a way, unlearn that approach, especially in the patients on Hemlibra. I think the other big area is around surgery. Thankfully, we don't do a lot of surgeries in pediatrics. Our patients are generally of an age where they don't need a lot of surgery, but I think we're gonna see a lot of changes there, and especially even looking at what's published about Hemlibra and surgery in children. A lot of it is taking out of central lines that aren't being needed anymore. But this is going to be a short-term issue because we're not going to have kids with central lines anymore. And so what happens when it's the typical kid surgeries, taking the tonsils out or significant dental surgery or injury-related surgeries from an orthopedic perspective, or taking out your appendix, right? It's going to be back to the kid surgeries that every kid might go through or might not, and really there's less literature about what's the best approach there. Having said that, I think a lot of us are, as pediatric treaters, are taking the approach of, rather than thinking Hemlibra might be enough and then seeing what happens after, is to give a dose of factor pre-op and maybe avoid needing post-op doses, because we can get a nice peak around surgery, and then as that wears off, we get back into the Hemlibra steady state that the patient has. And that may be enough for post-op healing and less bleeding. But again, depending on the surgery, that may change. And I think there's still a lot for us to learn because, as I said, the bulk of what's out there from an experience is central line removal, which is going to be a historical issue pretty soon. And then I think the last part is, are we kicking the inhibitor can down the road, as I like to call it? Because, we're starting to have minimally treated or never treated children who've never seen factor. And are they going to have inhibitor onset later? Is it going to be like some of our mild patients who get inhibitors later in life when they face either a major surgery or a major bleeding event? And is that what our pediatric patients are going to turn into? Are we going to start seeing inhibitors on Hemlibra when they get exposed to factor around injuries or surgeries or other situations where they need factor? And we're going to see it in adolescence, or it's not going to happen until they're with our adult treaters. And so that's something we have to think about. And then we had this big discussion yesterday that I think raised a lot more questions than answers at our pediatric meeting, where there's been cases of patients who maybe had inhibitors as children, were tolerized with immune tolerance. Hemlibra came along, and they transitioned to that. And then they had no factor exposure for a long period of time, and then had a bleed, needed factor, and their inhibitor came back. And then, so what do we do about that? Do we discuss immune tolerance again while on Hemlibra? Is that something that the patients are going to want to do again, to think about frequent IV access while on Hemlibra, which protects them from acute bleeds? But do we even worry about getting rid of the inhibitor? Is needing factor 7A periodically, because you still don't bleed on Hemlibra. It's very infrequent. And is that okay? Are some families might be okay with that? Some are like, no, I want this inhibitor gone. I want to use the factor I want to use, and I'm motivated to do that. Is that the right choice? And I don't think we have an answer for that yet. And I think it's a still unanswered question as to what's the best choice, and is it going to be different depending on the family situation? Some people will be like, nope, I'll take my chances on Hemlibra. When I bleed, I'll take my chances with Niastase, and hopefully that'll be sufficient. Whereas others may have a different view of that. So I think there's a lot to learn about onset of factor VIII inhibitors, either in patients who aren't going to get their 50 exposures early on in life. It's going to be, when they're much older, similar to what we see in mild hemophilia patients. And I think there's a lot to learn, and I don't have a good solution, but it's something I think a lot of us on the pediatric side are wrestling with. And I think I'm out of time, so move on to the next.
Thank you for the opportunity to come and to present some of the experiences that the physiotherapists have chatted about, and we talked quite a bit about it yesterday with some of the new products. So with advances in the medical treatment, physiotherapists, we must continue to strive for optimal musculoskeletal care for patients with hemophilia while adapting to some of these changes in patterns of bleeding that we've heard about. The introduction and the effects of some of the treatments in many patients with severe hemophilia are now experiencing a decreased ABR and milder bleeding phenotype, and the presentation of bleeding episodes may be different, as Cleveland talked about, and so there's new challenges that patients and clinicians must face. Mark already talked about that younger patients with hemophilia and their parents may never have seen a bleeding episode, and when they may not understand what's happening to their body when an injury occurs. And for older patients who have been advised for many years to recognize the symptoms of pain, swelling, and decreased range of motion as signs of bleeding. And so bleeding also triggers an inflammatory response, and so it's understandable that it's difficult to differentiate between bleeding, inflammation, and arthropathy. And so that's something that can be even more problematic when we're in the presence of steady-state products. In fact, one-third of painful joint episodes in patients with hemophilia with arthropathy is actually not associated with bleeding, but is due to underlying disease. So for clinicians, we're a variety of different people now. We may see people who are misinterpreting signs and symptoms of joint bleeds actually as bleeds instead of arthropathy, and we're also seeing patients who may be ignoring early signs of bleeds because they're not familiar what a bleed is like and they don't know what the first steps are to do, and then they're not presenting to the clinic until they have very significant bleeding events. So the key to best outcomes is to recognize and treat bleeds as they occur, and there are tools that patients and clinicians can use to assist both at home and in the clinic. The Hemophilia Injury Recognition Tool, also known as the HERT, is an app, and this is an innovative app that was originally designed for patients with mild hemophilia. It's an app that's designed to assist with self-management and to help patients with mild hemophilia to identify signs and symptoms of a bleed following injury. We know that patients with natural mild hemophilia show variation in their disease state and can develop long-term joint damage and experience social and physical limitations. My colleague Joanne Nielsen will be speaking this afternoon on the mild hemophilia session about the HERT app, but given the new milder bleeding phenotype, this app could be a very useful tool for some of our severe patients who are now presenting with a decreased ABR and less bleeds. As well as differentiating between bleeds and other painful episodes will continue to be important. And so point-of-care ultrasonography can be used in the diagnosis of acute bleeding and may be used for the detection of early synovial changes and cartilage lesions. And so most people in the room know the main difference between replacement and non-replacement therapy is the shape of the pharmacokinetic curve. Replacement delivers peaks and troughs, while non-replacement factor offers a steady state. A further key difference between the two is that replacement can be adapted to suit different needs, such as bouts of intense physical activity or physiotherapy sessions. And we don't know whether steady state is enough to allow for these activities without bleeding complications. And something that we're still looking at, and my colleague Julia Brooks will be speaking about that in this session on physical activity, because some of the literature is reporting extremely high levels of physical activity is what is being predicted to be needed for intense physical activity. And so previously, traditionally, both patients and physiotherapists, we would take a lot of comfort in the protection of the peak. And so when we don't have that protection of the peak and when patients are presenting to physiotherapists without having their factor right beforehand, it may lead, and we're seeing, and particularly in community-based physiotherapists who are not part of the HTC and who are doing the treatments in the home communities, is that they become a little bit more anxious in treating about patients with hemophilia because they're fearful that their intervention may cause bleeding. And so we don't know yet. Will this lead to less effective and more conservative physiotherapy management and poorer outcomes? And also for the patients, and Cleveland talked a little bit about it as well, is that the National Hemophilia Foundation reported that 50% of patients with bleeding disorders have a fear of exercise-induced bleeding. 50%, that's really high. And so following a bleeding episode, not treating in the same way that we have previously done may increase patient anxiety and may give them that sense of uneasiness of not knowing what to do, and that may complicate the patient's own pain experience during an acute injury, and it may also impact their engagement in their physiotherapy interventions. And so I think we can all agree that musculoskeletal status and physical functioning should be assessed regularly, and in the past several years, we've seen a big focus on the longitudinal joint assessment and outcome measurements. The HJHS, also known as the Hemophilia Joint Health Score, is the most widely used measure for people with hemophilia worldwide. And this is the International Classification of Functioning Disability and Health, which I'm sure everyone's familiar with. It considers structural and functional changes that can be assessed with measures like the HJHS, but it also considers activities and participation in the context of personal environmental factors. Using this holistic approach for patient care and to capture more subtle bleeding episodes and musculoskeletal problems that we may be seeing in patients with a milder bleeding phenotype, we need to consider recognizing a new core set of outcome measures that includes a critical examination of joint structure, but also potentially biomechanical function, gait analysis, point-of-care imaging, as well as patient reported outcomes and performance-based functional measures. That was my last word.
Okay, good morning, everyone. I think I have 5 minutes. Is that right? 3 minutes? Oh, of course, I'll run through my slides. Okay, what's going on here? Okay, so good morning. I'm Davide Matino from McMaster University. I live in Hamilton, Ontario. It's just full disclosure because when I think about, what are we doing with bleedings, treatment of bleeds on patients with Hemlibra, my first thought is, what's the evidence and what do we have in CBDR? So first, what's the evidence? There's not a whole lot of evidence, but there is some and it's growing. And in terms of what do we have in CBDR, there is some data that is interesting. I will not spoil it because there's ongoing research that will be presented, so I'll just give you a little bit of it. And I can tell you that, of course, the number of patients on emicizumab has progressively increased in our database. And during a 12-month period, about 30% of the patients reported bleeding episodes. So sure, it's not that common to bleed on Hemlibra, but there are patients that are reporting bleeds. The median number of treatments for these bleeding episodes for both bypassing agent and factor VIII was 1, which is sort of expected maybe, but still, it will be interesting to compare with what we were doing before, for example. Now, there are clinical practice guidance documents. Several organizations provided some recommendations, and I wanted to compare with what I'm doing in my center, what we are doing in our center. In the interest of time, I'll be very quick. In some cases, it's fairly easy to agree with what this experts panel have recommended, and it's in line with what we tend to do. But there are still some cases that are challenging, and there's very limited guidance. So I'll skip all of this. I'll just cut to this last slide. In particular, what I think is most challenging is the management of major surgeries, and in particular, orthopedic surgeries. We recently had 2 surgeries in patients with inhibitors on emicizumab, and the management is still challenging. It requires a very good team between the orthopedic surgeon, the physiotherapist, the nurse, the hematologist, and a specialized lab. It's not something that can be done without the proper resources. And the second, that it's even more challenging, at least for me, in my opinion, is the major cardiac surgery, coronary angioplasty, and the possible consequences, ECMO, for example. And I was just discussing yesterday with Dr. Teitel, we had a patient exactly in that condition not long ago, and it was so challenging to find the proper, best treatment for that specific condition. We don't have sometimes just the tool to deal with it. And just to add regarding to the injuries and the spontaneous bleed, yes, it's true. Sometimes it's minor things that don't require any treatment, but, and in some cases there is some over-treatment because of maybe anxiety, because it's what we were doing before, but I also want to highlight that delays in treating a bleed can have very severe consequences, and I think that we can all recall a case where a patient, or indirectly someone that had a bleed, was not treated because was on emicizumab, so maybe the treatment was delayed, and then the outcome, even if we then we started treatment late, the outcome was really poor. So I think this is something also we need to keep in mind, because the risk associated with the treatment in terms of thrombotic risk with a reasonable amount of factor VIII or a reasonable amount of factor VIIa, it's very, very low. So the balance depends still on the side of the benefits. Sorry, I was maybe too long. I tried to make it short. Thank you.